Hello, I'm Kelly Moore and the principal investigator of the American Indian Alaska Native What Can I Eat project. I'm Muskogee Creek and a board certified pediatrician on faculty at the University of Colorado School of Public Health within their Centers for American Indian and Alaska Native Health. I'd like to thank the organizers of the conference for this opportunity today to present to you, as well as my mentor at the University of Colorado, Dr. Spiro Manson. Nutrition education and diabetes self-management support have been shown to improve blood glucose and blood pressure management and decrease food insecurity. They're also important in the prevention and management of diabetes complications. The American Diabetes Association and the Shakopee Mdewakanton Sioux community of Minnesota came together with a really wonderful idea to adapt an existing ADA diabetes nutrition education program called What Can I Eat for American Indian and Alaska Native adults with type 2 diabetes. The ADA What Can I Eat consists of 5 2-hour nutrition-specific education lessons taught by a registered dietitian. It is one of the few diabetes education programs that is solely about nutrition. The program covers using the plate method, identifying carbohydrates and how to incorporate them into a healthy diet, learning how to cook and grocery shop, as well as eating out and dealing with celebrations as a person living with type 2 diabetes. Each session also includes a mindful nutrition component as well as a physical activity component. There is a need for a culturally adapted version of What Can I Eat for American Indians and Alaska Natives due to their disparate burden of obesity, type 2 diabetes, and food insecurity compared with the general US population. In addition, there were a few evidence-based nutrition education programs culturally tailored for Native Americans. During the first year of the project, we conducted a needs assessment with formative methods, including a comprehensive literature review to see what was already out there, a robust qualitative needs assessment with key stakeholders, and a health literacy review of the existing What Can I Eat materials to ensure readability and comprehension by our target audience of American Indian and Alaska Native adults with type 2 diabetes. I will be focusing only on the qualitative needs assessment in this presentation. Our focus groups were conducted in 4 unique American Indian community partner settings, 2 rural and 2 urban from across the country. 2 were based at urban Indian health centers with intertribal populations in Tulsa, Oklahoma, and Chicago. Our other 2 communities were reservation-based in rural settings, the St. Regis Mohawk community of Akwesasne. Their community actually straddles the US-Canadian border, and a tribal consortium of 6 tribes of Northern California in Lake County. These next slides provide more information about each of our community partners. And hopefully you can review these later. At our community partner sites, we conducted focus groups with community members with diabetes and their adult family members. We also conducted key informant interviews with tribal elders, registered dietitians, certified diabetes educators, and other administrative and support staff who serve these communities, and content expert interviews via Zoom with registered dietitians and certified diabetes educators from other sites in the Indian health system, researchers on food insecurity among American Indians and Alaska Natives, and other experts on health education program development and dissemination for American Indians and Alaska Natives. Some of the questions from our focus groups are listed here. All focus groups and interviews were digitally recorded and transcribed verbatim using a professional transcription company. The coding was facilitated by Atlas TI. The codebook was established using inductive and deductive coding techniques, and analysis was conducted using constant comparison methods to construct themes across all transcripts. One of our key qualitative findings was that American Indians and Alaska Natives are not a homogeneous group. There's considerable diversity between tribes, regions, and urban and rural communities. Even differences by ages were noted in our findings. Older adults have different needs, such as cooking for one, than younger adults caring for children, and all these differences need to be accommodated in a cultural adaptation. For each of our key qualitative findings, we developed recommendations for the cultural adaptation. These were included in a report for our funders at the end of year one of the project. For this set of findings related to the lack of homogeneity, we recommended developing more than 5 lessons so the facilitator and participants can determine which lessons pertain to their situation. For example, healthful eating while dining out, cooking for 1 or 2, etc. We also recommended the inclusion of placeholders for sites to tailor to their cultural needs, such as tribal or regional specific traditional foods and acquisition habits. We also heard that it was important to have a strength-based approach. This should include a traditional foods component that ties culture and traditions to a history based upon healthy, strong, and active ancestors as a motivational technique. In addition, we heard that a community-based education effort would work best. Considering extended family and community-based goals rather than just the goals of the individual with diabetes could make changes in diet and lifestyle easier. We therefore recommended including examples of traditional foods, a history of traditional foods, and how they can feasibly be a part of modern diets, inviting extended family or a support person to the classes, and in several classes, making time for intentional discussion about regional and tribal specific cultural foods. Accepted social norms about eating and feasting may need to be changed. Food is important for social gatherings and celebrations, but food served are often not the healthiest, and gatherings and events happen frequently. Community members need help translating healthful eating practices outside of class, and the education must go beyond people with type 2 diabetes. Our recommendations for these findings were to include an advocacy component to the curriculum to encourage healthy eating for the entire community, in addition to individual households, by asking event organizers to start offering healthier options or bringing healthier options oneself, and tips for healthy eating at gatherings. We also heard a lot about barriers to healthy eating. Some were environmental and related to food security and access to healthy foods. The high cost of healthy foods, limited access to supermarkets, but too much access to fast food and processed food. Lack of education on cooking and food preparation and healthy eating on a budget were noted to be especially true for younger parents. Lack of time was also cited as a barrier to healthy eating, and some participants shared a tendency to focus on convenient foods due to lack of time to shop, prepare, and cook at home. We recommended covering the following topics in the program: food resource management, such as meal planning, shopping, cooking, preparation, and storage, the use of commodity foods and healthful meals, healthful eating while away from home or on the go, and time management. For example, cooking several favorite meals once a week on a day off from work, freezing in individual containers, and eating these meals throughout the week. Qualitative findings related to class format were also noted. With regard to the educator, we heard that registered dietitians are not available in many communities, and that the educator should be an American Indian or Alaska Native community member. If not Native, then the educator should be a well-trusted member of the community who may have lived there for many years. A supportive, non-judgmental, non-shaming education approach should be promoted, and as well as meeting participants where they are. Having a Native educator and following this recommended approach for teaching the classes could also help with recruitment and retention of class participants. To address these findings, we developed a scripted curriculum that could be facilitated by a non-registered dietitian, but recommended the facilitator have access to a registered dietitian for questions, as well as the consideration to use technology, be that a simple phone call or something like Zoom, to provide access to a registered dietitian, including cooking, meal prep, tasting demonstrations, drawing, visual tools, and multimedia, as well as peer-to-peer discussions were all mentioned from our key stakeholders. We also heard that nutrition education should help people make healthy changes gradually so that they are not overwhelmed by feeling like they have to change everything at once, and instead focus on what is realistic given someone's life situation. We also recommended training and facilitating group discussions for the educators. Recruitment should be personalized and active with the healthy involvement of a community-based educator. Incentives such as cooking demonstrations and gift cards are valuable for retention, although attrition remains a concern. In terms of technology, access to the internet is no longer a barrier for most American Indian and Alaska Native adults, especially those in urban areas. Technology, social media, and videos could be a means to expand reach of the program. In fact, due to COVID-19, the next phase of the project, a pilot of the curriculum in our partner communities, was pivoted to be delivered virtually through an online meeting platform such as Zoom, and to perform all data collection as touchless, that is, online or remotely by telephone. Several limitations are worth noting and shared on this slide. In particular, it's not feasible to develop a separate version of the What Can I Eat curriculum for each American Indian and Alaska Native tribe and community. This may be considered a limitation for communities and tribes who prefer health education and resources specifically tailored to their own tribe. These findings have been used to inform the cultural adaptation of the ADA What Can I Eat nutrition education program for American Indian and Alaska Native adults with type 2 diabetes. The adapted curriculum represents a potentially crucial resource for Native communities for whom targeted diabetes nutrition education resources are scarce. We are now pilot testing the adapted virtual curriculum in collaboration with our partner communities. I would like to acknowledge and thank our community members, our content expert interviewees, the American Diabetes Association, and the Shakopee Mdewakanton Sioux community for their generous support, our wonderful site coordinators, our graphic designer, and the following members of the study team, Drs. Stotts and Braga. And thank you for Mado in my native language to all of you for your time and attention.